We are moving next session, most interesting session, interventional session. We are our director, Professor Mirjamaluddin sir, NICBD, also head of the department, National Heart Foundation, Professor Fazila Malik, also chairperson, Ibrahim Cardiac Center, Professor Muhammad Maximul Haq, sounds for everybody waiting for us. Thank you, Beximbo Pharma, for with us, courtesy. Thank you, Beximbo. Go from the next session, please. Next session, it is courtesy by Healthcare Pharmaceuticals. Next session. So I am requesting Professor Maximul Haq sir, Muhammad Maximul Haq, Professor A.K.M. Fazlur Rahman, Dr. Shams Panwar, Professor Khandaka Shohid Hossain, Professor M.G. Azam, Dr. Kajal Kumar Karmakar, everybody here. Now I am requesting Professor Muhammad Mamunur Rashid Sijar with Provisional versus double stent strategy in Bifurcation PCI. Professor Mamunur Rashid Sijar. Professor Caesar Bhai, please share your screen and start your session.
Thank you, Dr. Mohsin. First of all, Assalamu alaikum and very good morning to all the Cardiac Society members and respected chairpersons and faculties. Today's my topics is provisional versus double stent strategy in bifurcation PCI. Coronary bifurcation lesions account for 15 to 20% of all coronary lesions required PCI. Bifurcation is one of the most complex coronary lesions require endovascular treatment because the lumen of both the main vessels should be restored. PCI for coronary bifurcation is an ever-growing field with significant advancement in technique and technology. The best approach for the management of bifurcation should achieve the optimal procedural outcome, long-term success with low restenosis rate, low major advanced clinical effect. What is bifurcation lesions? There is a coronary bifurcation with two major artery branching. They have the components, three components. There is proximal main branch or vessels, distal main branch and vessels, side branch. Bifurcation lesions has suggest there is here chance of thrombosis, inflammation is more. Why bifurcation PCI is complex and high risk? Here the anatomical variation is present. There is Leibman bifurcation disease, plaque burden and location of the plaques, angle between the main branch and side branch, and dynamic changes in anatomy during treatment. There is chance of plaque shift and dissection and difficult to have perfect lumen reconstruction, incomplete coverage, and increased restenosis chart. So an appropriate therapy should be chosen to minimize the complication and for good outcome. Evaluation of the bifurcation PCI, initially the early stage, that is 1982, kissing balloon was performed for bifurcation of the bare metal stents, then provisional side branch stenting and gel wire, then come to the port and dedicated bifurcation stent. Nowadays, the two-stent strategy, decay crash and Culotte and others technique. There are several classifications regarding the bifurcation lesions, but the Medina classification is all accepted. There is a true bifurcation lesion is 111 and 0111. Now, why the bifurcation lesion has the unique challenge? Every lesion there is vessel shape and size. There is discrepancy in diameter in between the proximal and distal reference, and chance of plaque shift. Already I told the dissection and perforation. Then approach to the bifurcation PCI. The approach is dictated by the side branch, whether true or non-true bifurcation lesions, size of the side branch, extent and distribution of the disease of the side branch, how important the side branch is for that patient and for that specific anatomy. Angle from the main branch. Here is there is a algorithm. There is bifurcation treatment strategy. At first, we should see the side branch should needs to be preserved. If no, then we just keep it open? And if yes, that side branch should be preserved, then we should come to the things that side branch occlusion chance is low or high. If the chance of side branch occlusion is low, then we can go for the provisional stenting. And if the high, then we're going to do directly two-stent strategy. And here the angulation is one of the most important factor. If the angulation is 70 to 90 degree, then T-Stenting and Techniqu should be active. And in case of the less than 70 degree, decay crash and Culotte is the technique. Strategy of bifurcation already says that keep it open, provisional stenting and two-stent strategy. Keep it open in case of people when we will keep it open. Then when the side branch has ostial and diffuse disease and not suitable for stenting and clinically not relevant. In this case, there is a simple, that 6-fence guiding catheter should be placed and wire both branches, dilate the main branch if needed, stent main branch and leave wire in the side branch, post dilatation of the main branch with jailed wire in the side branch. Here is the case, there is less system CAG showing there is significant distal deplopment disease with significant lesions involving proximal and mid-segment element, and there is no significant lesion in the LCX, and LCX is non-dominant vessels. So we go for the keep it in procedure. That after wiring of the LED and LCX, distal left main and proximal LED was dilated, NC balloon. Then we positioning of the drug eluting stent from left main to LED. Deployment of the stent was done at 14 atmosphere pressure. Now the final result, there is no provisional stenting is needed and no two-stenting is needed. It is simply. Then provisional stenting, it is simple and fast, excellent short-term and long-term results, better long-term mortality, reserves all other options in case of failure. More than 60% of patients of left main bifurcation can be treated using the provisional technique. There is several randomized trial for between the provisional and two-stent bifurcation. Earlier, all the trial shows that better outcome regarding the target vessel revascularization and myocardial infarction. Provisional stenting is superior than two-stent technique. Here, the provisional, one of the trial, there is a Nordic trial, shows that for coronary bifurcation lesions, provisional single stent approach appears to be associated with lower long-term mortality than a systemic dual stent technique. And meta-analysis, there is 12 major studies, around 7,000 patients support the provisional single stenting. Another meta-analysis shows that the two-stent stenting is also good. How to select the provisional approach? The provisional candidate patients are the insignificant stenosis at the ostial SCS with Medina classification 1-1 or 1-0-1. Small LCX less than 2.5 millimeter diameter, non-dominant LCX, wide angle between the LED and LCX, no concomitant disease or only focal disease in LCX. Now, step-by-step provisional technique, it's simpler. There is insertion of a wire into the each distal branches, stenting of the main branch with a selected according to the distal main branch. The proximal optimization treatment should be done. Then guide wire exchange performed to a balloon inflammation. The jailed wire is withdrawn carefully to avoid the intubation of the catheter, and kissing balloon inflation is carried out with a preferably non-compliant balloon with distal branches. Proximal optimization is a very important part for the provisional stenting. Here, the pot is carried out after main branch stenting by inflating a short-term balloon just proximal to the carina. Advantage is the correction of the under expansion. Here is the chance of remaining under expansion in the proximal part of the main branch, which is covered by the after doing pot. Restoration of the proximal main branch circularity, facilitation of the side branch rewiring, scaffolding of the side branch ostium. How many cases the provisional stenting needed to the second stent? In case of Colombo study, which shows that around there is 30% patients needed second stent, but other shows that many less amount. Side branch stenting should be considered when there is significant side branch flow impairment, thrombolysis in myocardial infarction, that is STEMI flow grade 3, less than grade 3, in the presence of a major side branch dissection when the side branch disease and large enough to lead the significant residual injection. and when future access toward the side branch may be needed, so in that case we can introduce second stent. Which are the options for second stenting? The tap, reverse crush, and Culotte. Decay crush is not suitable for the second stenting placement. Two-stent in bifurcation techniques, double stenting needed between the 15 to 30% patient to achieve an optimal angiographic result in coronary bifurcation lesion. A two-stent technique is usually considered in bifurcation when the side branch is more than 2.5 millimeter with 50% stenosis and more than 5 millimeter beyond the lesions. The technical strategy where the side branch stent first continues widely upon use option in addition to provisional stenting. Definition 2 trial, which shows that the endpoints of death and myocardial infarction and target vascular regression is less in case of two-stent and then the provisional stenting. Here is the two-stent stenting directly takes in case of the complex bifurcation lesions. What is the complex bifurcation lesions? Complex bifurcation has the two major criteria and one major criteria and two minor criteria. Two major criteria, one is that the side branch disease more in case of left main coronary artery more than 70% in length more than 10 millimeter. In case of distal vessels, length more than 10 millimeter and lesions more than 90%. And minor criteria is moderate to severe calcification, multiple lesions, bifurcation angle less than 45 or more than 70, and thrombus containing lesions. These are the minor criteria. And what is the diagnostic criteria is one major and two minor criteria. Double stenting, there are several techniques for double stent technique in the T-Stenting and tap technique, crush technique, mini crush, Culotte technique, and double crush, decay crush technique. Double stent techniques depends upon the angle of the bifurcation lesions level in. Already I said that if the more than 70 degree T-Stenting and tap technique is suitable, less than 70 degree Culotte and crush technique and decay crush technique is the more suitable technique. Here we discussed just shortly, there is T-Stenting technique. It is simpler. That is at first the wiring and dilation of the both vessels and the stenting of the main vessels at first done. Then in the rewiring of the side branch and another stent in place and the kissing balloon was done. Here there is some there's some pitfalls. There is chance of uncoverage of the side branch ostium. To overcome this chance of uncovering the side branch ostium, tap stenting was introduced. The Culotte technique has the advantage that is in case of provisional technique, it can be takes as a second option when the second stent is needed. Here there is the distal vessels and side branch should be the similar size, and here at first the wiring of the both vessels was done, then the more angulated branch was stented and rewiring in the main branch or straight branch, then port was done and rewiring again into the side branch and double kissing balloon technique was done. Here the recrossing and the straight branch was stenting, then the kissing balloon technique was done. Final angiography shows that good result. IVAS shows the under expression in the Mohsin ki I continue or
hello software বন্ধ হয়ে গেছে জাস্ট প্লিজ সফটওয়্যার বন্ধ হয়ে গেছে না জাস্ট 1 মিনিট অন করো আবার অন করতে হচ্ছে
আচ্ছা আমি কনক্লুশনটা বলে দিই
না আপনি শুরু আবার অন করতেছে আপনি দেখেন আবার দাও স্লাইডটা দাও আবার সফটওয়্যার তো বন্ধ হয়ে যাচ্ছে স্যার স্লাইড চলছে স্যার আপনি শেয়ার দেন
আচ্ছা ওকে
শেয়ার দেন আবার সফটওয়্যার তো বন্ধ হয়ে যায় সব
আচ্ছা
আমাদের এখানে একটু সফটওয়্যার বানানো হয়েছে তো অফ হয়ে যায় Share the number.
Slide show.
Slide show দেখতে বললা যেতে
বাবা আমাকে তো যেখানে থামছি সেখানে যেতে হবে না
আপনি শেয়ার স্ক্রিন দেন অসুবিধা নেই
হ্যাঁ
তারপরে চলে
তুমি তাদেরকে আবার দেখাবা
হ্যাঁ এই যে ঠিক আছে
হ্যাঁ ঠিক আছে
আবার স্ক্রিন শেয়ার দিতে হবে
আবার স্ক্রিন শেয়ার দেন হ্যাঁ আপনার
স্ক্রিন শেয়ার দাও
জি হ্যাঁ নাইস দেখা যাচ্ছে
Sorry, actually, this is a big chapter, so I cannot complete. There is a double stent tech.
বলেন আপনি বলেন জি
just regarding the decay crash technique, then I completed. Here is the decay crash technique. Here the multiple procedure, step procedure. Here is the two port is done and the 2 times kissing balloon was done. Just I am showing the. What slide?
Yes. বড়দের পাওয়ার পয়েন্ট হ্যাং করছে সময় লাগবে 2-3 মিনিট
সিজার ভাই আপনি বোধহয় কনক্লুশনটা বলে দেন ওখান থেকে ল্যাপটপ থেকে আপনি বলে দেন জি আপনার মেসেজটা
আমার ল্যাপটপ আচ্ছা ওকে
জি বলেন জি আপনাকে দেখা যাচ্ছে ক্লিয়ারলি একদম
জাস্ট আ সেকেন্ড
জি জি
ঘরের সময় পেল না লাস্ট স্লাইডে চলুন
দাঁড়াও
Okay.
And the conclusions that the goal of the PCI in bifurcation is to attain the optimal results in main vessel and side vessel, maintain physiologic patency in the side bands, planning of the extremities upfront, and knowledge of the all possible bailout techniques and must be kept in mind. While provisional side bands should be default technique, low risk ক্ষেত্রে আমরা provisional stenting prefer করব আর হচ্ছে যে high risk or complex lesion ক্ষেত্রে আমরা Two-Stent technique. Although evidence is lacking as the superiority of the কোনো procedure যে superiority এরকম কিছু আমরা পাই না যে decay crash technique nowadays is more thinking that more superior than the tap and Culotte. Every procedure has some advantage. That is in case of Culotte the side branch ostium coverage in more, and in case of decay crash technique there is more reconstruction of the vessel is good, and IVAS and OCT should be taken for helping the bifurcation treatment of the bifurcation lesions. Thanks for all the organizers for the sessions. Thank you.
Thank you, Professor Mohammad Sidar, our dynamic treasurer of Bangladesh Cardiac Society. I'm requesting all the panelists, please finish your presentation within 12 minutes because it is a software generated program, so I said there will give some trouble. I'm requesting Professor Fazilatunisa Malik. He's the senior consultant, professor of cardiology, National Heart Foundation and Research Center. Madam, please share your screen.
Well, actually, the other that has to be switched off. Dr. Caesar's one has to be switched off, and then I can join. So,
Caesar, please share. Stop your screen. Okay, madam, everything is fine. Madam, share your screen.
Right, you can see me now, right? Okay, so chairpersons, yes, friends and colleagues, it's indeed a great pleasure and privilege for me to be here. I work at the National Heart Foundation Hospital and Research Institute, which is a 480-bedded tertiary cardiac care hospital. We started our journey in interventional cardiology in 1999 with a single cath lab. And at present, we have 5 fully functioning cath labs. And by the end of December 2020, from the inception of our first cath lab, we've done more than 46,000 PCIs altogether. And over the years, we have often had to tackle patients who had very complex coronary anatomy and also patients who were very hemodynamically unstable. And you will agree with me that one of the most complex subset of patients that we have can deal with is patients who have significant left main disease and come to us with ST segment elevation myocardial infarction. Hello. And indeed, these patients can have a very dramatic presentation in the cath lab. And such was the case of this 43-year-old male who was rushed to our cath lab in a collapsed state. His ECG, which had been done in the emergency, showed that he was having ventricular fibrillation. After defibrillation, he developed complete heart block. Temporary pacemaker was done. And as CPR was going on, we did the angiogram. And you can appreciate that the left side is totally occluded from the left main. As CPR was going on, we managed to wire the vessel as well. And we gave intracoronary adrenaline, which sort of jump-started the heart. We did pre-dilatation. And after that, we proceeded to deploy a 4x12 drug-eluting stent in the left main. And I'm very happy to say that this patient walked alive to his home. So we managed to save this patient, and 21 months down the road, a check and this check angiogram 21 months down the road. So ST segment elevation myocardial infarction with unprotected left main culprit lesions account for around 0.8 to 1.2% of all primary PCI interventions. And retrospective studies have identified cardiogenic shock, TIMI 0 to 1 flow, and cardiac arrest as the main prognostic factors for an unfavorable outcome. And studies have also demonstrated better outcomes with CABG as compared to PCI in patients with acute coronary syndrome and unprotected left main coronary artery. As compared to PCI in this setting. But realistically speaking, many times it will not be possible to arrange CABG so rapidly when a patient is in an arrested state. So logistically, it might be very, very difficult to do. And what about a patient who has already undergone CABG and comes to us with ST segment elevation MI, and we find that he has significant left main disease as well. And that was the case of this patient who came to us. His CABG had been done 3 months ago, and he presented with inferior lateral myocardial infarction and was in cardiogenic shock. So without further ado, we actually the outcome is a much better, and the mortality at 30-day follow-up when collaterals are present is 60%. When collaterals are absent and the patient is in TIMI 0 to 1 flow and in cardiogenic shock, the mortality goes up to 84.6%. And such was the case for our patient, a 40-year-old male who came to us with left main disease without any collaterals. And you can appreciate that the left main was totally occluded right after its origin. So there was a huge thrombus burden. We managed to wire both left main to LAD as well as left main to LCX. We did repeated thrombus aspiration, and after that, we stented just before the bifurcation. And this is the final result that we managed to achieve. So when a patient comes with significant left main disease and with ST segment elevation MI, without further ado, in our center, we usually try to do the primary PCI as soon as possible. Like in this gentleman who had extensive anterior myocardial infarction, he presented with cardiogenic shock. His angiogram revealed that there was 40 to 50% stenosis of the distal left main with thrombus. The LAD was also totally occluded with thrombus from its origin. We managed to wire the vessel. We did immediate thrombus aspiration, and we also gave the patient intracoronary adenosine and intracoronary adrenaline. And after thrombus aspiration, this is how the vessel looked. We started the patient also on GP2B3A receptor blockers. We then proceeded to stent from left main to LAD. After stenting, we noticed that there was significant plaque shift into the LCX with TMI 1 flow. So we knew that we would have to switch to a double stent strategy. And as the angle was suitable, we opted for a tap technique. So we placed a balloon in the LAD and took our stent for the LCX. We deployed a stent, we did final kissing, we did proximal optimization, and our patient survived and is doing well. So patients with ST segment elevation MI and thrombosis, when they're in cardiogenic shock, without doubt are a very high risk subgroup, and PCI is generally a feasible treatment option. A recent study has shown that in-hospital mortality for these patients who have undergone PCI is 32%, and the long-term prognosis is excellent in hospital survivors. So if we can discharge these patients, they have an excellent survival rate of 89.5% at 1 year. So doing a PCI for these patients is definitely worthwhile. Sometimes left main disease, especially distal left main anatomy, can be very, very complex. And interestingly, the initial complexity of coronary artery disease and the revascularization strategies, these have not yet been thoroughly investigated as outcome predictors in this subgroup of patients. However, generally, the consensus is that provisional stenting is the preferred strategy. Why? Because there is presumed less device manipulation, and also there is less chance of distal embolization. So for this very complex distal trifurcation lesion that one of our patients who came to us with STEMI presented, we tried to keep it as simple as possible. So we wired from left main to LAD, and then we did thrombus aspiration. After thrombus aspiration, this is how the vessel looked. And without further ado, we took a single stent, a 4x24 drug-eluting stent from the left main ostia into the LAD and deployed it. Luckily for us, there was no significant plaque shifting into the other branches, and the final result was quite satisfactory. When the thrombus load is very high, however, that's another story, and that makes the situation even more difficult. Like in this gentleman, his LAD, we could not visualize it, but there was a huge thrombus burden, as you can appreciate, from the left main to the LCX. The heart was barely moving. We had to do a temporary pacemaker. We managed to wire from left main to LCX. We could not wire the LAD. Looked like it maybe have been a CTO, but so after we had wired left main to LCX, we started doing thrombus aspiration. After thrombus aspiration, the patient went into cardiac arrest. CPR had to be started. He also developed respiratory arrest. We managed to stent from left main to LCX with a 3x24 drug-eluting stent. this is how the vessel looked. However, there was no pressure at all. So we decided that we needed to put in an intra-aortic balloon pump. We had already started all the maximum inotropes that we had in the hand. So after intra-aortic balloon pump, as well as all the inotropes going there, we saw that the pressure was reasonable, and we didn't attempt to prolong the procedure at all. We shifted our patient to the CCU, and we were lucky that we were able to discharge him 7 days down the road. We asked him to come back after a month. However, he took his time and he came after 4 months. And after 4 months, we did his check angiogram, and we found that the RCA, which was a severely diseased non-dominant vessel, was giving very great collaterals to the LAD. And maybe these collaterals were instrumental in the patient's survival. And the LCX, the stent that we had put 4 months ago, was well. However, there was a large OM that was occluded. The LAD was totally occluded from the origin, getting collaterals from the non-dominant RCA. So we sent this patient for CABG, and at present he is symptom-free. So our experience with left main is actually that we started doing left main PCI in 2007 on a regular basis. And by the end of December 2020, we have done a total of 2,430 left main cases in our hospital. And I'm very happy to say that even in the COVID era, in 2020, we did more than 300 left main PCI in our hospital. And what about an experience with ST segment elevation MI? From 2007 to August 2020, we have tackled a total of 5,280 STEMI PCI. Of this, primary PCI was done in 1,437 patients. And if you divide this primary PCI, the PCI patients, total PCI patients, the vast majority was obviously non-left main, but in the STEMI with PCI, 228 patients had left main disease along with ST segment elevation myocardial infarction. And we've done left main coronary artery PCI, primary PCI in 30 patients. So if you look at the age distribution of our patients, over 80% of our patients were above the age of 50 years. And regarding sex distribution, 87% were male. If you look at the risk factors, these patients were pretty sick. 54.8% were diabetic, 54.5% had some or other form of chronic kidney disease. And regarding the ejection fraction, the vast majority had some or other form of impaired systolic function. We have managed to follow up the vast majority of our patients. 9 patients were lost to follow-up. Our median follow-up period is 33 months. And if we did check angiogram for 22 of our patients, we found that in 2 patients, they had developed ISR. And we, as I said, we followed up our patients, and our overall MACE is 12.3. And with this experience, I think the most important factor for success is the teamwork. And from the entire team of National Heart Foundation Hospital Research Institute, who continually inspire me, I would like to say thank you to the Cardiac Society for giving me this opportunity. Thank you.
Thank you. Excellent, madam. You finished just allocated 12 minutes. Thank you, Professor Fazluddin Malik. Excellent presentation. I am requesting Director of NICBD, our teacher, General Secretary of BSCI, Professor Mir Jamaluddin sir, will talk on radial versus femoral approach in complex PCI. This session is courtesy by Healthcare Pharmaceuticals. Thank you, Healthcare Pharmaceuticals, with us. Professor Mir Jamaluddin sir, please share your screen.
Yes.
I need to unshare also.
Yes.
Sorry about I got sort of.
Mir Jamal sir,
yes. I am hearing you. Do you hear me?
Nicely, sir.
Good. Thank you. Respected President, Secretary, and Scientific Secretary, and other panelists and dear audience. Assalamu alaikum. My topics is transradial approach versus femoral approach in complex coronary lesion. It is well known that nowadays all over the world, radial intervention, as because the procedure is same, but procedure is last side. Are you seeing motion? Are you seeing me? My slide?
It is seen, sir.
The radial? Okay. If I answer, both son and daughter are same. That is why we can go both femoral or radial approach as you like. But I am doing almost all the cases in radial approach, preferably distal radial since 2017 December. And there are different trials regarding this transfemoral versus transradial approach. And here you see the benefits and risks of transradial approach, less benefits, particularly in primary PCI, earlier ambulation, patient comfort, and risks also there, longer procedures, more contrast, longer flow time sometimes, longer due to wire crossing time sometimes. And there are several studies. The rival study is taken approximately 7,021 patients, and their result is death, MI, and stroke, all in favor of transradial approach, but there is no significant difference with femoral approach. And Matrix trial, they have also shown the all-cause mortality and death, MI, stroke, all in favor of radial approach, but not significant. And in STEMI radial result of 1 year, and here also shows all in favor of radial, though only the bleeding is significantly low in transradial approach. And recently it is seen that in primary PCI there is also mortality benefit. Madam showed transradial percutaneous coronary intervention for left main bifurcation lesions using 7.5 French sheathless guide catheter, and they have concluded the PCI for left main bifurcation disease by transradial approach using a 7.5 French sheathless guide catheter not only is feasible but also provides high efficacy with acceptable result. And left main percutaneous coronary intervention, radial versus femoral access, a systematic meta-analysis was done, and they have concluded that patients undergoing PCI for LM disease via transradial approach have with less bleeding, reduced access site complication or vascular complication, reduced in-hospital mortality, comparable procedural success, and possibly better long-term clinical efficacy when compared to those undergoing the procedure via transfemoral approach. Then transradial approach for coronary total occlusion, transradial CT approach. And radial versus femoral, there are different talks, all in favor of radial approach. And trends and outcomes of radial approach in left main bifurcation percutaneous coronary intervention in drug-eluting stent era two-center study, and they have shown no statistical significance in MACE, mortality, MI, and stroke. So we shall have to successful radial in first approach, get access quickly, with that works for you, and know how to manipulate it, understand when it is time to cross over and get out safely. And this is the milestone of transradial approach. All of us know now we are in the era of transradial intervention for endovascular procedures, structural heart disease, and reduced radial artery occlusion rate. And this transradial, we know that started in 1980, late 1980, and now it is all over the world, approximately in UK approximately 90, USA approximately 70%, and in Europe approximately 60 to 70%. And Bangladesh perspective, in Bangladesh, transradial route has been used for coronary intervention about 15 years back in a limited arena. Though it has a long learning curve, still it is preferred by most of the interventionalists, and TRI is used for about 40% of intervention procedures in Bangladesh. And there are different latest procedures of transradial intervention. TRI in distal radial approach, combo technique, BAT, virtual sheathless technique, use of left guide to cannulate the RCA, patent hemostasis technique, use of glide cylinder, all we are doing. And the benefits already we have shown in other studies. Radial device compatibility, we should also know it. The 5 friends, 6 friends, 7 friends. Most of the cases is done by 7 friends. So there is no need for going to femoral for doing complex anatomy. And the guideline also says 2018 is and irrespective of all patients, but a graduated level of center and operator experience is recommended before TRA is pursued in with acute coronary syndrome. Complex PCI in transradial approach, our initial experience, 7 friends guide, it is done by virtual sheathless approach. You see the guide, sheath is out and guide is inside. And by radial approach, and this is the scenario. Coronary artery, and second strip shows the PCI done after the result. This is the 7 in 6 French sheath that is we use for 7 French guide in transradial approach. And here we see distal left main disease and almost 1-1-1. And one thing is important, that circ is almost double than radial. You should carefully see it. And we have done it with the IVAS, pullback IVAS, and this is the IVAS result, pre-procedural, and this is the process. Procedure is going on. And balloon dilatation, LCX stent is placed. Here the LCX stent is 4.5 into 12. And balloon in the LED, LM to LED is 4. And this is balloon stent deployed, and first kiss is done here, and then first crash, stent deployed, second crash. First crash was done by the balloon, and this is the second crash by the stent, and recross the LCX, and we have opened up the LCX strut, and final kissing was done, and on the right panel, and this is the report, and this is the result. This is the result after the procedure, and this is the result of IBUS after the procedure. And bifurcation PCI in radial, you see this RC is all right, but LED main stenosis as well as LED and LCX osteoproximal. Procedure is going on, wiring the both vessel, and the stent is deployed LM to LED. And here you see this is another balloon, this gelled balloon technique I have done. This balloon is gelled into the left circumflex, and the result after the procedure. This is the result after the procedure. here all the pages is not, all the slides are not seen due to time constraint. And PCI in anomalous RCA, for anomalous RCA, we tell, are you in femoral root? Let us come to our radial root, and you will be able to do it very nicely. It's not showing. M plus guide, and this is the angioplasty. So we can do all types of complex cases as well as abnormal origin, and this is another case where this is the arterial luxuria with CTU. And let us see what is the result after angioplasty. This is the pathway of the catheter. And this is the final result after opening the CTU and doing the stent. Then take message: radial approach is safe and feasible as new technique for coronary angiography and interventions. Both approaches good, depends on operator choice. Radial approach has long learning curve, and all types of complex PCI can be done in radial. And we can conclude that integrating the ability to comfortably perform transradial PCI, especially for the highest risk cases, should be a goal for all interventionalists perform primary PCI. Be a critical skill
Thank you, sir.
set for all interventionalists.
Thank you, sir. Timely finished within 12 minutes for learning for our participants also, how a presentation finished within allocated time. Thank you, sir. I am requesting Professor Mohammad Maksumulok, sir, Head of the Department of Cardiology, Ibrahim Cardiac Center Research Center. Professor Maksumulok, sir. Professor Mohammad Maksumulok, sir, do you hear me, sir?
Yeah, I can hear you.
Thank you, sir. Please.
Assalamu alaikum. Thanking the Cardiac Society for arranging the annual conference. And I'd like to congratulate all the three speakers for their nice, simple, and very elaborate presentation. First, Professor Mamun Rashid, he talked about bifurcation stenting, which is always challenge, as one has to stent the main vessel and also preserve the side branch. And it is more challenging if bifurcation involves large vessels like LED and LCX, as in left main. Sometimes we think of one strategy and has to change the strategy during the course of the procedure. So one has to be conversant with all methods and adapt. Still then, it is better to master one or two methods than others. So it is a whole new, it is a very big chapter, and he has nicely summarized in a short 10 minutes time. Professor Fazila Malik, great interventional cardiologist, known all over the world, and she has shown.
Sir, video on করবেন স্যার, আপনার ভিডিও অন করবেন স্যার।
এটা কেন জানি একটু প্রবলেম হচ্ছে এটার মধ্যে, হ্যাঁ আমি এর মধ্যে।
জি স্যার।
And she has shown not only stenting of a bifurcation lesion like left main stenosis, which supplies more than 80% of the left ventricle, and preserving the left main, preserving the LED and LCX, and also in an acute situation. And we have heard a lecture from someone who is a master in this field, and it can be successfully done by probably very few in this country, and one of them is Fazila. But I sometimes think that it's easier for the performer to do a STEMI in left main situation, because in any case, if you don't do it, most probably the patient is not going to survive. And I tell from my experience, these cases are never accepted by surgeons. And Dr. Fazila has shown one thing, that about 1,400 primary PCI was done in last 14 years, which comes to about 100 primary PCIs per year. And if we come down to 12 months, 100 patients. So I think the number is low. And this reflects that there is a low turnover or STEMI to our primary PCI sites at proper time. And Professor Mir Jamaluddin, regarding radial and femoral, we have heard it from a pioneer in this field, and he has mastered all the techniques of radial. From our experience, we are doing it for over a decade, and tell all the newcomers in this field that try to do all cases, not only simple cases, all complex cases through radial, and then only you can become a master. And also the primary PCI, because it does not take too much time. And I do not believe in the saying that it is a long learning curve. This is really not a long learning curve. Learning depends on the person. So if you try, everybody can do a radial. So thank you, everyone, and thanks the Cardiac Society, especially the President, Secretary, and the Scientific Secretary for arranging such a beautiful yearly seminar. Thank you all.
Thank you, sir. Thank you, sir. One question from Major Mohammad Bayajid. Raise his hand. Major Mohammad Bayajid, do you hear me? Major Mohammad Bayajid. Okay, I'm waiting for him. Professor A.K.M. Fazlul sir just called me. He's in village, so cannot join his program. Dr. Sams Monwar. Dr. Sams Monwar, Senior Consultant of Eberke Hospital. Dr. Sams Monwar. Dr. Sams Monwar, sir. Sams Monwar দেখতে পাচ্ছি স্যার আপনাকে স্যার। Please unmute, sir. মাকসুমুল স্যারকে দেখতে পাচ্ছি আমরা এখন ভিডিওতে। ডক্টর শামস মনোয়ার স্যার, কামরুল। I think net problem in there. Professor Khandokar Shohid Hosen. Professor Dr. Shohid Hosen.
Thank you.
Okay. Yeah.
Thank you. Hello.
শুনতে পাচ্ছি আপনাকে। আপনি শুনতে পাচ্ছি।
আচ্ছা। Okay. Thank you to all. Today's discussion was actually bifurcation lesions. Professor Mahmoud Sajar, who discussed about the bifurcation lesions in usual way, but Professor Fazlul Malik, she described in ST elevated MI cases, especially in left plane. And Professor Mir Jamal sir, who discussed about the test radial approach even in complex cases. I want to say something regarding the bifurcation stenting, especially provisional versus double stent technique. Previously, all the randomized trials showed that provisional stenting is good or best. But now, when we go through the DK-Crush 2 or definition trial, there are some argument, and I think the most important thing, whether we should go for single stent or double stent, is the size of the blood vessel, stenosis, percentage stenosis, STEMI flow, and the length of lesion. Especially, and this is not true for, this is not all the same for left main lesion and the non-left main lesion. Left main lesion, this is especially important. And in left main bifurcation lesion, actually, we are thinking all the things, what we are seeing, this is very important for left main lesion. And so I can say that this is the operator must have some inner side of the bifurcation lesion. That is the how important is the vessel. And a technique, the DK-Crush is the best technique by definition to trial. And Professor Fazlul, madam, what he said, I have some query here. Actually, the total revascularization, in primary PCI nowadays, we are doing total revascularization. But in primary PCI of left main disease, when there is bifurcation lesion, whether we should treat the both lesion or whether we should put one stent or double stent in STEMI case, especially in STEMI case. If the patient is, there's recurrent arrhythmia or the patient cardiogenic shock, yes, there is importance of the stenting or primary PCI, but if the patient survive or if the patient regained his blood pressure, if patient improved from a cardiogenic shock, whether we should go for second stent in that setting or we should defer it for later period. Thank you.
Well, thank you for the question. I think we should definitely, it is very individualized. Now the guidelines tell us that in a shock patient, we should just treat the culprit vessel. And usually patients who come to us with STEMI and left main are very sick, and we try to keep the procedure as simple and as possible and stage the procedure, go for total revascularization at a later date. But if there is significant plaque shifting, like in one of our cases that I showed, there was such a lot of plaque shifting in a large size LCX that we had no option but to go for double stenting. So intuitively, we try to keep the procedure as simple and as short as possible. But if the patient can tolerate it, or if we see that there is no other way out from this procedure without double stenting, then we go for that. But usually we try to keep it as short and as simple as possible. Thank you. I hope that answers your question. Thank you, Shohit.
Thank you. Thank you, Shohit bhai. Any comment, Shohit bhai? Any question, Shohit bhai?
No, okay, thank you. Thank you.
Thank you so much.
Okay, thank you.
Dr. Anisil Hawal from Chittagong. Do you hear me? Dr. Anisil Hawal? Dr. Anisil Hawal, he raised his hand. Okay, I'm waiting for Anisil Hawal. Then Professor M.G. Ajam. Professor M.G. Ajam, Professor of Cardiology and ICBD.
Thank you. Thank you, Scientific Secretary Dr. Mohsin Ahmed. It is a wonderful session. Really, I appreciate it. The event is taken by our dynamic leadership by Professor A.K. Mahibullah, President BSC, Bangladesh Cardiac Society, and our Secretary General, Professor Abdullah Shafi Mojumdar sir. Take the time-demanding initiation, and today's scientific event nicely covered by Professor Mahmoud Rashid Caesar and elegantly case showed by Professor Fazil Malik and Professor Mir Jamaluddin. Nothing to say, everything is covered. One thing I just tell to our fellows and audience, left main PCI, it is a large area PCI, so it should be very careful and very important. We know high volume operator, if perform any left main PCI, there is 30 days mortality rate 8.8%. And if low volume operator, there are 30. So we should be. Then we can proceed. Then we can proceed our further complicated cases like ostial, then shaft, then bifurcation. Once system you adopted, then you go for next system. That will be the take-home message from my side. Thank you very much, and thank you very much.
Thank you, Dr. Kajal Kumar Karmakar. Dr. Kajal Kumar Karmakar. Dr. Kajal Kumar Karmakar, do you hear me? Dr. Kajal Kumar Karmakar. Dr. Major Mohammad Baijid, do you hear me? Dr. Anisul Awal?
First of all, on behalf of Bangladesh Cardiac Society, আমি আমার এই ইন্টারভেনশনাল এই সেশনের তিনজন স্পিকারকে আমি অকুণ্ঠ ধন্যবাদ জানাচ্ছি তাদের ব্রিলিয়ান্ট প্রেজেন্টেশনের জন্য এবং আমি ভেরি হ্যাপি যে আমাদের তিনজন এক্সপার্ট তিনটি বিভিন্ন বিষয় নিয়ে যেভাবে প্রেজেন্ট করেছে দ্যাট উইল বি ভেরি ফ্রুটফুল টু দি অডিয়েন্স এটা আমাদের একটা ভালো বিষয় এবং ভালো ইন্টারাকশন হচ্ছে এখানে বিভিন্ন জন বিভিন্ন প্রশ্ন করেছেন এখানে অন্যান্য ফ্যাকাল্টি আছেন, যেমন খালেদ মহসিনকে দেখতে পাচ্ছি। ইউ ক্যান মেক কমেন্টস অন দিস, কারণ এই সেশনটা তো খুব ইম্পর্টেন্ট ইন্টারভেনশন সোসাইটি। প্রফেসর মামুনুর রশিদ সিজার, প্রফেসর ফজিলাতুন্নেসা এবং আমাদের প্রফেসর মীর জামাল, তিনজনই দিকপাল, তিন দিকের। কাজে কোশ্চেন বা কমেন্টস, খালেদ মহসিন, ক্যান ইউ পার্টিসিপেট প্লিজ? আনমিউট প্লিজ। আমাদের ইন্টারনেটে ঝামেলা হচ্ছে নাকি না?
ডক্টর আনিসুল আওয়াল, তুমি আনমিউট করো। ডক্টর আনিস, প্লিজ।
Thank you, sir. I have the question. The GK crash is very important, and on the different studies, it is better than other techniques for complex bifurcation lesion. My question is, in the periphery where we don't have the IVAS, should we try without IVAS the GK crash in left main?
Fozila, madam.
Well, actually, the thing is, it's not, IVAS is not mandatory to do DK crush, actually. But one thing is that Professor Ghulam Azam has highlighted, and that is that high volume center. Like if a high volume center does DK crush almost every day of the week, it is a lot easier to do it there, where the necessary teamwork and the necessary setup is there. And IVAS is a extra bonus, but it is not mandatory. And I think you should gradually build up to DK crush, because DK crush has a lot of steps. But it is definitely, if you do it on a regular basis, it can be done in the periphery as well. IVAS is not mandatory. But one point that Professor Ghulam Azam made is very important. The team as a whole should be conversant with the steps, and it should be reasonably, it should be a reasonably common procedure for that center. IVAS is not mandatory. Thank you.
Thank you. Dr. Khalid Mohsin. Dr. Khalid Mohsin, sir. Please unmute yourself. Professor Khalid Mohsin, sir.
Yeah, thank you. Thank you. Very, very nice session, actually. Particularly all the speakers, they have they have showed that difficult things look incredibly easy, actually. Particularly Fazila Madam's lecture was really very challenging cases she has shown in the setting of primary PCI. It is very difficult at the odd hours, and the less experienced operators are in the cath lab. So it is a very challenging scenario. And Professor Mamunur Rashid's lecture was also very good. And I think these lectures will instill some courage and words of judgment in our younger cardiologists, so that they can venture into this difficult terrain of interventional cardiology with a lot of confidence in future. Thank you so much.
I say Professor Maximulok sir raise his hand. Professor Maximulok sir.
Just a comment about the left main stenting. In my personal opinion is, those who are newcomers, they should probably do IVAS in left main, because unless the stent is properly apposed, which sometimes we miscalculate, because we usually think the size is lower, usually the size is higher. So there may be restenosis and the patient may come back. And I have seen a lot of cases coming back who did not do IVAS. This is just my opinion. And IVAS is basically not a complex procedure, and also not very costly if you reuse the catheters. And catheter can be reused. I have seen it. Catheter can be used 4 or 5 times.
Thank you, sir. Nicely commented. You should use the IVAS in left main PCI. Dr. Swadesh Chakraborty from Khulna. Dr. Swadesh Chakraborty, please unmute yourself. Dr. Swadesh, do you hear me?
Sir.
Yes, sir. Yes. Yeah.
Thank you, sir, for giving me the opportunity. And thank you, Bangladesh Cardiac Society, for arranging such a nice program. I must thank Professor Mamunur Rashid Sizar sir, Professor Fazila Malik sir, and Mir Jamaluddin sir for their nice deliberation. And I think arrangement of such a program will definitely help us like our junior cardiologists like me to improve our skill and to encourage us to perform the procedures. Thank you, sir, for a nice arrangement.
Any question from you for periphery? You're doing lots of cases in Khulna, I saw. Any case of bifurcation? You see, you do bifurcation in the Joshua, Khulna?
Sir, actually, bifurcation, the Ghulam Azam sir nicely mentioned, the bifurcation case volume is very low in periphery. As you know, the logistic supports and we also performers are not very much trained for performing the bifurcation case, and leftmen, we usually do not perform the leftmen, but some cases in provisional stenting and LED bifurcation or LCX, a few cases we perform bifurcation case and provisional stenting mainly.
What about radial, Dr. Swadesh? In the radial cases, Mijamans are here. Any comment for radial in the periphery?
As a periphery, radial cases are increasing, and we are trying to perform all cases in radial route. First, if we fail, then we go to femoral route. The most cases we try to first radial route, and if any complication or if we fail, then we go to the femoral route. And now in Khulna, I think around 70 to 80% cases are done in radial route.
Comment from the Professor Mamunur Caesar. Professor Mamunur Caesar regarding for the periphery, how to develop the periphery in bifurcation. For the periphery, for the you see already
already
provisional issue to the provisional. Okay.
Yes, I already showed that the provisional stenting can be done in bifurcational around 65 to 70 cases. That is a big number. So for Swadesh, you are rightly in that track that at first the provisional stenting should be done. And here the patient selection is the important. That is the side branch lesions. That is the properly evaluated the risks of the blockage of the side branch in the procedure. This should be calculated and probing should be carried out. And later on, bifurcation two-stenting will be also done.
Thank you. Thank you, Professor Shofik. Dr. Shofik, please come.
Thank you, madam, and thank you, other speakers for their nice deliberation. Actually, I just want to add something. In peripheral centers, I worked in right now working in central the center, and I also worked in peripheral center. So I have to face so many left main cases, and actually we need to have the courage because in the periphery we don't have any IVAS, but we need to handle the left main STMI as well. So we did. I could do one case in peripheral center and patient survived, but we could not do several cases, patient could not survive. That is very important. So we need to have the courage. Without having IVAS, we should handle this case in the cath lab. Otherwise, patient will not able to come to Dhaka. So we have to do something else in the peripheral center for the patients. So we could do one center that patient survived, and we could not do several patients could not survive. So that is also important. Thank you.
Nice comment, because primary PCI is the most important thing. We should do something that referred to that in Dhaka. Professor Mijjamal sir, for the periphery, I think radial is promising. Dr. Swadesh, Dr. Anis doing the radial cases. Professor Mijjamal sir, do you comment, sir? Professor Mijjamaluddin sir, do you hear me? I have got one message from Professor Khalid Mohsin, only son of Dr. Onu Shastra, member of Bangladesh Cardiac Society. He's the working in Square Hospital, died in tragic road traffic accident in Canada yesterday. He was an undergraduate student there for last 2 years. He's only son of Dr. Onu Shastra. Let us pray of the departed soul and try to console the dear patient. So, Amra Poribarer Poti. Professor Khalid Mohsin sir, do you say something regarding this? Professor Khalid Mohsin sir.
Actually, I heard the news last night and I was
waiting for a confirmation. She is from Nepal and she got married in Dhaka. She has become a very pious Muslim now, and she has got one son and a daughter, and this son was studying in University of Manitoba, Canada. And last evening, he had a tragic road accident, and because of the bad weather, he was driving possibly, and he could not be rescued alive actually. So it's very tragic actually, and let's pray for the departed soul and let Almighty console the parents for this irreparable loss. We expect your prayers.
Sir.
Actually, this is a very tragic news and it touched our heart. Let us have prayer for the departed soul, let us have sympathy for the parents.
Thank you all the chairpersons, speakers, and our participants. Now it is 12:30. We should conclude our session now.